Welcome to KJR SummaryCast, audio summaries of peer-reviewed articles published in the Korean Journal of Radiology. This recording has been created and submitted by the authors and may have been generated using AI tools. While the article has undergone formal peer review, this audio has not been verified or edited by KJR. We encourage listeners to also refer to the published article for the most accurate and complete information.
When you think about getting a handle on a thyroid nodule, you'd hope it would be, pretty straightforward. But here's something surprising. Actually figuring out if certain types, these follicular-patterned neoplasms, are harmless or, something more serious, can be really tough with the usual methods.
It really can. It's like trying to spot the one slightly off apple, as you said. These follicular pattern types are tricky because the cells, they look pretty similar under the microscope, benign or malignant.
Okay.
Ultrasound gives hints, sure, but it's often not definitive. And the standard first step, fine needle aspiration, or FNA, it's useful often, but it definitely has its shortcomings with these specific nodules.
Right. Okay, let's dig into this then, because this is exactly the puzzle we're tackling in this deep dive. We're looking at some really interesting research that directly compared two biopsy methods for these challenging cases.
That's right.
You've got the standard FNA and then core needle biopsy, CNB, which takes a slightly bigger piece of tissue.
And this wasn't just a small study, it's pretty substantial. A large multi-center effort across 26 hospitals over in Korea.
Wow, 26?
Yeah. They examined, 5,463 thyroid nodules. These were all 1 centimeter or larger.
Okay.
And they came from 4,883 patients. So the scale, it really adds weight to what they found.
Absolutely. So think of this as your fast track to grasping what this huge study tells us. No need to wade through dense medical journals. We're pulling out the key stuff for you right here. Our mission, really, is to figure out which method, FNA or CNB, gives a better diagnostic result for these follicular-patterned neoplasms, especially when the biopsy comes back as Bethesda 4.
That follicular neoplasm category.
Exactly. And interestingly, the study actually used that Bethesda 4 result as the specific benchmark, the sort of test positive criterion they were measuring against.
Right. And just so we're clear on the terms they use, diagnostic yield in this context meant something specific. It was the proportion of nodules confirmed as follicular pattern neoplasms after surgery, specifically among those that got a Bethesda 4 result on their biopsy.
Right.
Relative to all the nodules that underwent biopsy initially.
Got it. So out of everyone biopsied, how many with a Bethesda 4 result actually had the target neoplasm confirmed later by surgery?
Precisely. And then there's the false referral rate, or FRR.
Okay.
Similar idea, but it's a proportion of those Bethesda 4 cases that, after surgery, turned out to be something other than a follicular pattern neoplasm. Again, relative to all nodules biopsied.
So how often did a Bethesda 4 result lead to surgery for something that wasn't the main thing they were looking for?
Exactly. And the final word always came from the surgical pathology, looking at the actual tissue post-removal.
Okay. This comparison is crucial because, as you touched on, FNA isn't perfect for these follicular types.
No, it isn't. Because it mainly collects loose cells, it sometimes just can't provide enough information to say for sure if it's benign or malignant. You lose the structure.
Which leads to?
Well, often inconclusive or non-diagnostic results.
Right, and that's frustrating. It can mean more tests, repeat biopsies, more waiting, more anxiety.
Or even going straight to surgery just to get a definite answer, which you'd rather avoid if possible.
Definitely. So CNB is proposed as maybe a better option here.
The thinking is, because CNB takes a small core of tissue, it actually preserves some of that tissue architecture, the way the cells are arranged together.
Okay. So FNA gives you the bricks. CNB gives you a glimpse of the wall.
That's a good way to put it, yeah.
Yeah.
And that structural information, that wall, it can be critical for differentiating benign from malignant in these follicular cases.
Okay. And here's where it gets really interesting based on this study, because they found CNB had a significantly higher diagnostic yield than FNA for identifying these follicular pattern neoplasms when that Bethesda 4 result came back.
Right, a really big difference.
And this was true both before and after they did statistical matching to compare similar patients and nodules.
The numbers were quite dramatic. Before matching, CNB's diagnostic yield was 9.0%. FNA's was way down at 0.5%.
Wow.
And even after carefully matching the groups, considering age, sex, nodule size, KJR category, all that, CNB was still at 9.0% yield compared to FNA's 0.6%.
Still a huge gap.
A huge gap, and statistically highly significant. Very unlikely to be just chance.
So what does that actually mean in practice? It means if you got a Bethesda 4 result in this study, CNB was much, much more likely to have correctly flagged a true follicular-patterned neoplasm compared to FNA.
It was just better at finding them when that initial test was positive. Yeah, dramatically better.
Okay, but the follow-up question is crucial. Did it lead to more unnecessary surgeries? What about that false referral rate?
That's the critical balance, absolutely. You want accuracy, but not at the cost of too many false alarms leading to surgery.
So what did they find there?
Well, they looked closely. Before they did the matching, CNB did have a slightly higher FRR. But, and this is key, after they matched the groups to make it a fair comparison, that difference vanished statistically.
Really?
Yeah. The FRR was about 0.4% for CNB versus 0.1% for FNA post-matching, but the p-value indicated this wasn't a significant difference.
So the big boost in finding the actual neoplasms with CNB didn't seem to come with a significant penalty in terms of unnecessary surgeries triggered by that Bethesda 4 result.
Exactly. That's a really important finding. It suggests you gain diagnostic power without a major downside in terms of false referrals, at least based on this data.
Good. And just to round out the picture, they also checked the positive predictive value, the PPV.
They did. That's basically asking, if I get a Bethesda 4, how likely is it really a follicular-patterned neoplasm?
Right.
And for both methods, the PPV was actually very high, over 90%. And importantly, there wasn't a significant difference between FNA and CNB on this measure.
Okay, so when either test says Bethesda 4, it's usually right that something follicular is going on.
Pretty much, yes. The main difference revealed by the study is how often each test gets to that informative Bethesda 4 diagnosis when a follicular neoplasm is truly present. CNB just seems to get there much more often.
Got it. Now, the researchers went even deeper, didn't they? They looked at the specific types of these follicular-patterned neoplasms.
Yes, the histological subtypes. And this was fascinating, too.
What did they see?
CNB pretty consistently showed higher diagnostic yields than FNA across almost all the different subtypes.
Okay.
This included benign ones like follicular adenoma and also various malignant types, follicular carcinoma, minimally invasive follicular thyroid carcinoma, the follicular variant of papillary thyroid carcinoma.
So, benign and malignant types.
Generally, yes. CNB appeared better at identifying a whole range of these different follicular entities when they were present, and the biopsy was Bethesda 4.
That's quite comprehensive, but you said almost all subtypes. Was there an exception?
There was one, yes. Widely invasive follicular thyroid carcinoma, WIFTC. For that specific subtype, which thankfully isn't the most common, there wasn't a significant difference in diagnostic yield between FNA and CNB.
Okay. An important detail shows that, nuances always exist.
Exactly. No test is perfect for everything.
And they also slice the data by patient groups and nodule features, like age, size, ultrasound appearance.
Very thoroughly. They looked at age, sex, nodule size, those KJR categories from ultrasound, which estimate risk.
And did the CNB advantage hold up?
Largely, yes. CNB generally maintained its significantly higher diagnostic yield across these different subgroups. They specifically mentioned, for instance, the odds ratios for nodules classed as KJR 3 and 4 in ultrasound, showing a really substantial benefit for CNB in terms of diagnostic yield in both those risk categories.
So it wasn't just working well for one specific type of patient or nodule, it seems.
The benefit appeared pretty broad based on their analysis.
Okay, so let's think about the clinical side. What's the potential impact here? This research really suggests CNB could, significantly improve how we diagnose these tricky follicular cases.
It really points that way. If CNB is more effective at nailing the diagnosis with the Bethesda 4 result, it could mean getting the right answer sooner.
Right.
And that could potentially cut down on those repeat biopsies we talked about.
Which nobody wants.
Exactly. Or reduce the number of surgeries done just because FNA was inconclusive.
Yeah.
Ultimately, it suggests a path towards better, maybe more efficient management for patients with these types of nodules, especially those landing in that Bethesda 4 zone.
Now, we should also acknowledge, like any study, this one had limitations. The researchers pointed them out themselves, right?
Absolutely, and that's good practice.
Wow.
They noted it was retrospective, looking back at data.
Okay.
And while they use matching to try and control for biases, you can never completely rule out some selection effect. They also mentioned that the final pathology reviews weren't centralized. They relied on the reports from the 26 individual hospitals.
So some potential variability there.
Potentially, yes. But it sounds like they were very rigorous despite these inherent limitations.
Yeah, acknowledging limitations actually builds confidence, I think. Shows they've thought critically about their results.
I agree. And the sheer size of the study, the multi-center aspect, the matching they did, it all lends considerable strength to their main findings, despite those caveats.
Okay, so we've really unpacked this quite a bit. Let's try and crystallize the main message, the key takeaway for you listening.
Okay, so the bottom line seems to be this. When a thyroid biopsy comes back as Bethesda 4, suggesting a follicular neoplasm core needle biopsy, CNB, was significantly better in this large study at actually confirming one of those neoplasms was present compared to standard fine needle aspiration, FNA.
And crucially,
this higher diagnostic success with CNB didn't seem to come with a significantly higher rate of unnecessary surgeries once you account for differences in patients and nodules.
so what does this all mean for you? Well, it highlights how diagnostic approaches evolve. This research suggests CNB offers a real advantage for getting clearer answers with these specific, often ambiguous, thyroid nodules.
It means potentially more accurate diagnoses sooner, perhaps fewer repeat procedures, and a more direct path to the right management plan. Where FNA might leave uncertainty, CNB seems more likely to provide that needed clarity in these Bethesda 4 situations.
And understanding this kind of nuance, knowing that these different biopsy options exist and might be better suited for certain situations, well, that can empower you.
Definitely. It helps you have more informed discussions with your doctors, ask perhaps more specific questions about why one approach might be chosen over another in your particular case.
It's a great example of medical knowledge moving forward, refining tools, which leads to a final thought, perhaps. Given these findings, how might the way doctors initially approach biopsying certain thyroid nodules start to change? Could we see CNB becoming, maybe, the go-to first step in specific scenarios, like when ultrasound flags feature suggestive of a follicular lesion?
That's a really interesting question to ponder.
Or even taking a step back, what other diagnostic puzzles in medicine might benefit from this kind of head-to-head comparison, pitting established methods against newer or alternative techniques to see what truly gives the best, most efficient answer for patients? Something to think about.